Yeah, she has regular insurance.
Now, how in the world can we be so happy to get Medicare patients when doctors are actually getting out of medicine or kicking out their Medicare patients because of the things that BooBoo Kitty's doctor is
Yeah.
So I think we'll jump subjects right now.
Jump subjects. Sure.
Okay. So
Go ahead. Go ahead. I'll let you take lead.
This is the CCM podcast.
Go on.
Welcome. This is Dr. Mark Vaughan and Dr. Gwen Vaughan, and we're talking about chronic care management, which is Medicare's new way to make it worthwhile for doctors to take care of Medicare patients with chronic conditions. In the old days, we would see a doctor, we're the doctor. We'd see the patient. They'd see us, the doctor.
Yes.
Intermittently, every 3 months, every 6 months, every 2 months, depends on how bad whatever's going on is, how often you need to get them in to address that issue. I'll put you on the phone duty here.
I am. I'm watching.
Because we actually can take live calls while we're putting this out. That old model would pay us a certain code we would bill according to how difficult the visit was, how complicated the medical issues were. At the time of the visit, there's up to 5 categories, but really we only use, in the real world, 2 most of the time, sometimes 3.
Right.
Depending on how difficult, how complicated, how many problems there are, how many medicines we're managing, how many labs we're checking. How much we don't like spending time in the room with that patient. No, I should not have said that. The way of doing that doesn't really reimburse the doctor for things that go on between visits. And a lot of people say, well, that's expected. Maybe. To take phone calls, to follow up on lab results, to make a referral to a specialist when something comes in weird on the labs, call up the patient, make all that coordination. Well, that's taking you out of seeing the patients in the office where you actually do get revenue, and actually it can build up quite a bit with patients with chronic health conditions. It can be a lot of stuff. So Medicare started this thing called CCM, Chronic Care Management, where they pay the doctors monthly to call the patient, not the doctor themselves, but their office, somebody that's got some kind of medical certification, medical assistant or nurse, and they'd speak with the patient. They get caught up on all these things. They go through, we were talking earlier about these templates and things programmed in the computer. They go through those things with the patient to make sure they are up to date on all of these things that do come up intermittently. Get the labs ordered, get them checked, make sure the doctor looks at them, adjust medicines accordingly. And then we do need to get the patients in actually physically to the office for certain examinations like diabetic retinopathy eye exams with their eye doctor, or foot exams with us or their foot doctor, listen to their heart and lungs once or twice a year. There are some things that you do need to do in person and with your hands and ears and eyes, and we still do those things. But all the in-between stuff that would take up time in the doctor's office unnecessarily, we can do that over the phone with a medical assistant or a nurse. Get all these boxes checked so that when the patient comes in, for one thing, we're able to look at the patient instead of a computer screen, getting all these boxes checked because somebody we pay to do it took care of that. And we're also able to address whatever it is that's actually concerning the patient. Patients actually have things come up, especially when they have chronic health problems. Stuff comes up. That would be another assessment on that list of things that we're writing when we're writing the diagnoses. So what I think of mainly when I think of this is diabetes and hypertension.
Those are the most common.
Those are the 2 big things. And then after that comes the kidney dysfunctions that come along with those as a frustration of those, and hyperlipidemia, which also complicates and makes you have more risk for stroke. Anyway, stroke, another one on the list. I'm going to get lost here unless you pull me back.
Yep. Come back.
Anyways, we're checking all these things with visits monthly. We get paid a little bit. Now, here's what Medicare found. Or it wasn't Medicare, somebody else did the study that found that after doing this for 18 months, Medicare was saving $74 per patient per month, even after they were paying the doctors about $40 or so a month to do this stuff. They were still coming ahead, $74 every month, every patient this is done on, which sounds crazy. Where's this money coming from? Well, I'm glad you asked. It's coming from inpatient to hospitals, inpatient payments, and skilled nursing facilities. These are the places that take care of the complications that people with chronic conditions end up getting when they're not managed well. So we save a lot of money with a single hospitalization that we avoid on a patient. So much that it makes it worth it, not only for them, for us to make these monthly calls, but also for all the other people with the chronic health care conditions that wouldn't necessarily have had to have gone to the hospital. But it's so worth it to keep people managed tightly and well and keep them in good health. This includes all the medical stuff I've been talking about, but also lifestyle things. We're spending more time reminding them and going over things like diet and exercise and not smoking and not drinking or not drinking too much. These are incredible things when it comes to savings of healthcare dollars down the line, to the point that that's actually a big part of our practice now. Because we're doing this, we are able to be in a better place financially with Medicare patients than we were with the old model. So I understand why doctors are saying, oh, it's too much, I don't want to take that on, I don't want to set up that program. And we also have seen that, yeah, it is kind of complicated, and yeah, it is kind of a big deal, to the point that we had to hire an entire new employee to do this. And I'm making a instructional series for doctors on it called CCMPays.com. Pretty catchy, huh? Because the reason CCM pays is because it pays in health benefits for the patient, it saves Medicare money, and the doctor actually comes out ahead compared to if they're not doing it. So CCMPays.com, it's really just for doctors, but other people can look at it and see what it's about. And the reason we call it CCM Pays is because a lot of doctors are looking for a way to do this, and they're just hiring it out to somebody else that's going to take half the payments.
Yeah, it's pretty ridiculous.
A third to half. But really, it seems to be more like half of the payment is going to somebody outside the doctor's office. And now it's not the people you know in the doctor's office treating you and calling you and following up with your doctor. It's got this middleman thing instead of being right there in the office. So I'm trying to encourage doctors to do it themselves with their Medicare patients, with somebody in their office that their patients already know. They know their voice because they see them when they come in the office. So that's why we made CCM Pays, and we're still working on it, but people can look at the website and kind of see how it's coming along. We're going to have the actual templates there for them fairly soon. I got through about a quarter of it just this afternoon.
Excellent.
Putting it up. I'm sorry, I've been talking too much. You've been just listening. What's our audience? What's their take on it?
Not much.
It's not a lot of Medicare patients.
Yeah, the thing is that
watching
I don't
YouTube
know how much
and, I mean, some,
but yeah, it is a very good thing that is will help out primary care practices.
I'm
in the long run.
excited for the future of it because we're going to be able to not have to have the patients come back, every 3 months in person.
Yeah, that's a big thing.
It's going to free up the office a little bit. We're still going to be in contact with them, but just not making them come in, making the MA take their vital signs, taking up a room, taking so much of the time out of their day, whatever time they have to wait. Not that we like people to wait for us. We try not to do that to people, unlike some of the other doctors' offices we hear about.
So I guess the question is, how would you guys feel about that once you're Medicare age? Some of you, that's a long way off. But would you want a doctor to call you monthly? We have had a fairly overwhelmingly positive response to this.
Yeah.
I would say.
Well, every once in a while there'll be somebody who says, "Why do you call me for? Don't take me off this list."
Yeah.
It happens.
Well, it happens.
But you have to understand we have
run into those people.
What, 280 patients now?
Is that where we're at? Wow.
Yeah, I think we're at 280 right now. Again, it has to be people with 2 or more chronic health conditions on Medicare. Here's another thing. The cost for it is covered by Medicare, but like anything with Medicare, there's a copay. Well, that copay is covered by people who have secondary insurances, their Blue Cross or Aetna or whatever, or AARP that pays their copays. If it's paying it, I tell people, get it, because it's only going to be something that gives you better health in the long run, and cuts down on things that possibly could happen. So the people who straight Medicare without a secondary, which they may actually take that copay away. There's rumors that may happen.
Yeah. Probably...
for them, I'm not as quick to bring it up. Of course, if somebody's independently wealthy, especially if they have congestive heart failure, which I'm thinking one patient in particular, I will bring it up and they will say, yeah, that makes sense. I'll do that. It works. But we're looking forward to a time when hopefully that copay will be covered for the people who don't have secondaries. Thankfully, in our practice, most people do.
Right.